So now we'll move to back to our educational heart failure. So the session now is state-of-art management of chronic heart failure. For that, we have three great speakers from Germany and from UAE, and I'll ask my colleague, Professor Rosano, to introduce the first speaker.
So it's my great pleasure to introduce Professor Michael Boehm from Germany. They will discuss the RAAS, ARNi, and MRAs and beta blockers in patients with HF and reduced ejection fraction. Please, Michael.
Ladies and gentlemen, dear colleagues, it's my task to discuss with you the effect and the position and the new guidelines of RAAS inhibition, ARNIs, as a family, then the mineralocorticoid antagonist and beta blockers. So these are my disclosures. I would like to make 3 points, and that is the concept and principles of the design of guidelines, then when to start, and then the issue of ejection fraction and what was new concerning these class of drugs. So what are the principles? So here you can see that indeed heart failure is characterized by a downhill slope of left ventricular ejection fraction, which is influenced by disease modifiers and comorbidities, but in particular by risk factors, what means if they are antagonized, there is an amelioration of these progressive remodeling. And among them, there are neuroendocrine players, which is norepinephrine, angiotensin II, and aldosterone, and all of them are associated with a progression of remodeling and clinical deterioration. And therefore, it becomes clear that these class of drugs, which are the topic here now, ACE inhibitors or ARBs, beta blockers, and spironolactone or eplerenone as MRAs, indeed have provided beneficial effects of outcome and also on the structure of the heart, so they can indeed improve remodeling. And this indeed has led to the position of these drugs as key players in the treatment of heart failure. And they have been sequentially investigated, as you can see here. SOLVE treatment against the empty background reduces by 4.4% mortality in 1 year. It was followed by the beta blocker, and it was followed by the MRA in patients with stable heart failure. And you can see that altogether these drugs are able to more than halve the mortality of heart failure. And therefore the new guideline, and that is a position, did not change anything because there is nothing new, and therefore they have to leave and have to stay as a class 1 recommendation. However, if there are novel mechanisms like heart rate reduction, neprilysin inhibition, heart rate reduction close to beta blockers and neprilysin inhibition with 81 blockade close to the RAAS inhibitors, what are they doing? And indeed, we know that heart rate is an important risk marker and also a risk factor. This has been shown here in the SHIFT trial. Every increase of heart rate is associated with a significant percentage of increase of risk for cardiovascular death and heart failure hospitalization. And as with the neuroendocrine hormones like heart rate, it is the same. Reducing heart rate, placebo-controlled by 10 beats, leads to a reduction of cardiovascular death and heart failure by 18%. And therefore, in this, the position of the guideline is when it comes to the subgroup of patients with a heart rate and sinus rhythm above 70, due to one trial with a split endpoint, hospitalization positive, you can see it's a class 2A recommendation. It's just one trial, therefore B. So 2AB for ivabradine. If they are intolerant for ACE inhibitors, it's a recommendation class C because this is based only on expert opinion because there is no dedicated trial. Another mechanism are the ARNIs, of course. So this is another add-on mechanism because it's not only blockade of this pathway, it is also an improvement of these weakened pathways which are protective to natriuretic peptide. And here you can see why that is so. If the concentration and activity of neprilysin is high, which is a red curve, there is a 20% increase of cardiovascular death and heart failure hospitalization or cardiovascular death alone. And this might indicate that there is indeed a causal role of neprilysin inhibition in chronic heart failure to produce outcomes. So inhibiting these enzyme, which is breaking down these peptides, leads to an increase of their bioavailability, and in concert and in agreement with what has been said before, to a 20% reduction of outcomes, highly significant, low likelihood of error, and you can see the curves diverge only. So these are the new mechanisms, and therefore the recommendation and the position of sacubitril/valsartan clearly is class 1 should be given, definitely, but it's a B because it's only one trial. It's a large trial, many discussions about it, but still it is one trial big enough to give him a 1B. But don't judge too much the B, judge the 1 before. So the question is now, what does it matter? Shall we combine them all? And there is a meta-network analysis of a couple of years ago comparing all of these drugs which are discussed here now, and in addition to see whether there is an add-on effect of combining them. And what you can see, and this is cardiovascular death, the more intensively they are combined, the lower is the risk, indicating that indeed of these drugs, the combination makes sense as progressively there is an improvement of outcome. Now, when to start? So this is the old guideline, and the data I've shown you of these drugs, they are sequentially introduced, and then they are slowly titrated up. And you can see the only change was made in the 2012 and 16 guidelines due to the CBIS-3 trial, where then it was allowed to give ACE inhibitor and beta blockers together. But still, there is a strong and very conservative sequence of the drug. However, there is concern that postponing treatments might lead to an increase of events. And indeed, when you look at this, and this is here the paradigm study, here you cannot see anything, but this is the secondary analysis we have done very early after publication of the trial. You can see that these curves separate after approximately 10 to 14 days, and even in 13 days, it is clearly significant, indicating that the effects start early. So starting late means losing the patients here in between the curves and therefore producing events. And this is not only the case with the eplerenone. You can see with paradigm, that is paradigm. It can also be observed with solved, after 14 days, and with Copernicus, where the treatment starts early to become positive, and of course, and this will be given later in this session for the SGLT2 inhibitors, because this is Emperor and this is DAPA, so they also act early. So the concept is to start with them together, and that is new. Everybody who is, of course, overloaded needs a loop diuretic, but now the recommendation is start with all of them all of a sudden. The other thing is, what about patients who are in the hospital? They have the worst prognosis, and then they have still a very bad prognosis in the so-called post-discharge in the vulnerable phase, 10 to 30% deaths into 3 months, and then it levels out in the chronic phase. And what we know is that there are few trials, in particular the successful ones, which have studied inpatient here, except some of them like Soloist, Galactic, Victoria, and one study, which is a pioneer study, which deals with sacubitril/valsartan. And they looked into patients who were acutely decompensated and very early recompensated, and then after 24 days being off of IV drugs, they initiated either sacubitril/valsartan and enalapril. So, and you can see here this exploratory outcome, because it was not powered to be an outcome study. Again, they separate early with a very low number needed to treat until you can see the first 56 days. So therefore, an early treatment in the hospital makes apparently sense. And furthermore, it does not matter whether these patients have de novo heart failure or whether they have been treated with an ACE inhibitor or not, because unloading, according to the change of NT-proBNP on the left-hand side, and the composite endpoints did not differ. So the recommendation, mainly driven by this trial, is initiation of sacubitril/valsartan should ESMA first be a replacement, 1B, I talked about that, but in the hospital, it can be given in de novo patients with a 2B subgroup analysis, small study, not powered, evidence level B, because, of course, it's not a dedicated trial. and only one piece of evidence. So that is what is here. And in general, when taking it seriously with a C evidence level, all the drugs should be given during the hospitalization. It is recommended that evidence-based oral drugs should be administered before discharge. Then we can be sure that it is continued after discharge, and that might provide the best protection. Now, what about ejection fraction? Any new things with these drugs? So this is the old definition. In 2016, there was mid-range ejection fraction introduced, 40 to 49%. And this is a new one, which means it's mildly reduced ejection fraction. So this has a connotation because it's reduced, that these are sick ventricles, 41 to 59. So how does it come? So this is a continuum and the distribution of ejection fractions in patients with heart failure from the ESC registry. Here we have positive outcomes, neutral outcomes heretofar, but in these patients, no evidence, and therefore they were never being treated, although the ventricle now is regarded to be sick. So now what do we know? You can see that indeed, between HFpEF and HFrEF, the effects are very close together. This was a clear positive trial. Paradigm-HF, I referred to that before, but the Paragon trial has a trend. Only 7 events were lacking to make it positive. So the same, and that is not new, was indeed investigated in the CHARM program. You can see this is preserved, and this is CHARM reduced, and you can see the difference is really small. However, the p-values are different. So therefore, there is a trial, which is Paradigm and Paragon and CHARM, which were put together with imputed control groups from the CHARM. And then they looked at the treatment effect over the whole spectrum of ejection fractions. And what you can see that indeed at a cutoff approximately at 55 to 57%, there is a reduction of risk indicating that the drugs work here. And for the drugs we are discussing, it is the same. These are secondary analysis. I put that together for an editorial. Sacubitril valsartan works from here. TopCat works from here. Beta blockers, even individual patient data, has positive findings in seniors in this group. And also the CHARM trial works, indicating that these drugs work in this area of question, which is mid-range or mildly reduced ejection fraction. So that's indeed has been taken up in the guidelines. You can see these are sub-analysis. So it's not a one recommendation, it's 2B, secondary analysis from pre-existing trials. And C means that is the interpretation. If these patients are congested, they need a diuretic, that is a class A. So therefore, that is another new finding concerning these drugs. So neuroendocrine activation is a success story. It founded the effects of RAAS inhibition, aldosterone antagonist, and also of beta blockers. New mechanisms, when they come into play, usually they have an add-on benefit like neprilysin inhibition, sacubitril valsartan, and heart rate reduction. And early treatment, starting with all of them together, combining these mechanisms provides the best benefit, and treatment beyond HFrEF in mildly reduced ejection fraction is now recommended with a class 2B/C recommendation. Thank you very much for your attention.
Thank you very much, Professor. Questions, comments from the audience here. Please, Sharif.
There is a presentation in the European Society of Cardiology and Hypertension from Australia. They use one tablet containing quadra doses of the 4 drug. Do you think, doctor, that something like this could be applied in the hypertensive to start the 4 with a very small dose and all together to go in the next 4 weeks or 2 months? Did you hear my question?
Michael, did you hear the question?
Yes, I hear. So do you hear me as well? Yeah, that's nice. So in heart failure, it's a little bit too complicated to do fixed pill combinations, fixed dose combinations, because usually it should be handled flexibly, all the drug doses. However, there are ideas to combine the mineralocorticoid antagonist with an SGLT1 inhibitor, but that requires for approval a study, and this study is ongoing. Yeah, but it's a good idea because that might increase adherence to drug intake.
Yeah, it's very interesting. I've seen that research. So, any beta blocker I mean, most of people, I don't know if this is real or not, placebo, or I mean, people say maybe bisoprolol got some, more side effects than the other new one, third generation. I mean, anyone in the heart failure, you think to?
Okay, beta blockers, we have 4 drugs where the evidence has been shown, and that is metoprolol, carvedilol, in Copernicus, and bisoprolol. Nebivolol is studied in a population of elderly patients, so it's a little bit a specific population. Then there was a COMET trial comparing metoprolol and carvedilol with a slight improvement in favor of carvedilol, but also with slightly more pronounced blood pressure effect. So I don't think there is a big difference. The highest numbers are given to patients here in my country, in Germany, is bisoprolol presently. And carvedilol has an alpha effect, which might a little bit more decrease the blood pressure. And there is another thing that we have a fast and slow metabolizers for metoprolol. So if somebody stays up with heart rate, he can have a CYP2D6 mutation, and then it is better to switch to another beta blocker. Or if somebody really drops with heart rate, and that is 7% in the population, there are poor metabolizers. So an adverse event on metoprolol should lead physicians to switch to beta blockers. So that is something which should be kept in mind.
Michael, one question on beta, to stay on the beta blockers. Now, there's and we've raised this question earlier on the target dose, but we also have meta-analysis that show that what is important for beta blockers is the reduction in heart rate. So
Absolutely.
what is your approach? What is your view?
I think that is an interesting thing, and Professor Rosano and myself, we have done a paper on patient layering. So there is a meta-analysis from an author called Flannery, which he was in the group of Henry Crum, and they did something like a regression meta-analysis, a permutation analysis showing that the parameter to be most closely associated with the benefit of beta blocker is heart rate, and it's not the beta blocker dose. So if a patient has a high heart rate, it might be wise to start with the beta blocker, maybe even adding ivabradine, which facilitates uptitration of the beta blockers in heart failure patients to get heart rate down, because we expect a rather huge treatment effect. In patients with a low blood pressure, with low heart rate, but maybe high blood pressure, it might be advisable to change or start with an ARNi and then add the beta blocker later. It's not the first one, which might be important for layering. And Professor Rosano has also put that together in the European Journal of Heart Failure, individual patient characteristics, and among them is blood pressure and heart rate, in addition to kidney function disturbances and atrial fibrillation, are crucial for the layering of the drugs, but the message should be 4 drugs as fast as possible. So, and then add the beta blocker in particular when heart rate is high. So, to be precise.
Yeah, Michael, with the progressive more information we're getting about ARNi and the ARB, what's going to happen to ARB and ACE inhibitor in future?
So usually there is a position paper from the European Heart Failure Association, and also I think in clinical practice physicians used to start with an ARNi. And if you then look at the Pioneer HF study, which shows in the hospital the start of therapy shortly after recompensation of the patients, 50% had de novo heart failure and no ACE inhibitor, and the other one had an ACE inhibitor, and you can see it's exactly the same. So here, usually we start with the ARNi, yeah? In the guideline, because the evidence have more data on ACE inhibitors, so it's a 1A/1B recommendation, because it would look a little bit crazy to say 1B and then /1A. So therefore, in the figure, it is ACE inhibitor ARNi, but in the text, there is a class 1 recommendation for exchanging it as soon as possible.
And for MRAs, you know, we have some new ones coming, third generation. I know that, again, you need to look at the outcome, but should we replicate what happened? I mean, these have less side effects compared to the spironolactone, even eplerenone, the new one. So how should we start this one and get experience with it?
Let's say it has few side effects. There is no direct head-to-head comparison of spironolactone against finerenone, so that would be interesting to see. That is not really incorporated in the guideline because one of these studies just came out lately. Yeah, it is mentioned in the text, but it's not in the official recommendation. And by the way, also the differentiation between spironolactone and eplerenone in the 2012 guidelines, we voted and declared the class effect. And this was also done because in all the countries which are covered by the ESC guideline, not in all countries, eplerenone was available at that point of time.
Okay, any question from, because the reason I'm delaying this discussion because the third speaker will be delayed, that's why. So any question from you guys before we move to the next speaker? So Michael, thank you very much for your excellent speak.
Thank you very much.
Right.
Bye-bye.